Hello and welcome to today's webinar, Emergency Preparedness, Preparing for the Coronavirus. I'm KJ Wrigley with Fast Staff Travel Nursing. It is my pleasure to introduce our speaker today, Kim Windsor. Kim is the Vice President of Administration for Fast Staff. With 3 decades of experience leading clinical and HR teams and extensive staffing experience, she is no stranger to today's topic. And with that, here's Kim.
Hello, everyone, and thank you for taking time out of your day to join us as we talk about emergency preparedness. We did record this webinar a little bit over a year ago and wanted to bring it back out so that we can provide information and assistance to those of you that are facing the current situation in the United States with the coronavirus. We understand most of you have well-developed emergency plans, and we are not saying that we have the silver bullet to solve all of your situations. However, we would like to circulate some ideas that we have learned over the years working with clients in emergency and crisis situations. Hopefully, this will provide you 1 or 2 new ideas that are a takeaway to go back and strengthen your existing plan. Here is the agenda that we're going to follow during the presentation. The focus on emergency preparation is going to be broken down into before, during, and after segments. And in each segment, we're going to organize it by technology, process, and people. We thought that breaking it up in this fashion would give you small chunks, easy to organize takeaways that can definitely help you as you are analyzing your plan and listening to the concepts presented here. When we talk about emergency preparation, again, I mentioned earlier that this presentation was created in the past and we've updated it with the current event of coronavirus, but we need to talk about emergency preparation in the larger scope because there are many underlying principles that can apply to a variety of emergency situations. Currently, we are in the flu season. We've had a relatively moderate season in 2020, but as with all emergencies, it's a perfect example. It is unpredictable. Hospitals have made their preparations for the normal flu season, and now unexpectedly we have a new strain of the flu that is becoming prevalent in the United States and can definitely cause situations of staff shortages, limited resources, disruption of the status quo. So as we're talking today, that is the reason for the discussion. However, please don't compartmentalize it for just that purpose. Emergency preparation needs to happen for a variety of situations, whether it's the natural disasters that occur, the fires, the hurricanes, the floods, any seasonal event that really causes devastation. There are acts of terrorism that unfortunately are more prevalent in our society than they ever were before, and that is completely requiring the need for planning ahead and being prepared. When I was working in a hospital in Pennsylvania, we always had to be prepared for industrial accidents or community accidents. We had the I-90 corridor running through our part of the city, and there was always the risk of spills, waste, chemicals being accidentally discharged into the environment, and how we would manage that event so that we could preserve the safety of the community and the residents. Other areas that we don't think about as much when it comes to emergency preparation, but they actually require the same level of planning and resource management. If you think of hospitals that are unionized, the event of a labor disruption, if there is a strike by one of the nursing unions that affects the staffing of the hospital, that has very serious community impacts for patient safety. And not to be jovial about this at all, but even if you look at EHR conversions, most hospitals have their EHR established and they're comfortable, but now they're getting into phases of upgrades, their second, their third upgrades. And if that's not planned for and we haven't looked at staffing and resource considerations, it very well could be devastating to the hospital and to the patients. I was talking with one of my CNO friends a few months ago, and she was going through her conversion and said it was one of the most difficult planning scenarios that she had to work through. Just the number of details and considerations were almost overwhelming. And she said that she truly wished she would have been more methodical and used the disaster planning scenario in prepping for the EHR conversion. So even though the cause of the disruption, the disaster, the emergency may vary from seasonal occurrences of the flu, natural disasters, or anything causing this disruption, the bottom line is be prepared. Do the necessary planning, involve your coworkers, your peers in the organization, really rip off the Band-Aid and see what are your processes, what's the technology situation, what are the people constraints, so that you can be prepared and be able to hit the ground running in case you are in a situation that requires emergency deployment and planning. We're going to jump into the different segments that we introduced earlier. The first, of course, being before. And this is the time when you can really establish being in control as much as possible. I know that sounds like a contradiction because emergencies are just that. They're unpredictable, they're unknown. You can't control them completely. But what a good disaster emergency plan will do is help you establish as much control as possible so that you can decrease variation, so that your outcomes can be more predictable, so that you have the building blocks, the infrastructure in place, so that you can deal with what the unknowns are in a situation. So this is a time when you really need to get your plan in place. You need to know what the technology, the process, and the people opportunities are, and establish as much control as possible. The first component to talk about is technology. As we introduced in the agenda, technology itself can even be its own source of emergency. We worked with a client a while ago that was going through an EHR conversion, and it failed. So they had to revert back to a manual system. And there were a lot of hiccups in that. They needed more staff. Just to document manually required many more resources in the staffing solution in order to make sure that the notes are entered, the assessments are done. Everything had to be painstakingly worked through while they were trying to get back up on their EHR platform. So yes, it can be a disaster in itself, but outside of that, technology really has to be tested, and this is a great opportunity to work with your CIO or CTO in the organization and really help him understand the implications of not having the ability to document, not having the ability to chart. Some of the roadblocks are as simple as having access to technology. We worked with a client that their process to establish the nursing ID took 3 days. Not that anybody wasn't doing their job. It was just a process that had to go through so many different people and channels that for a new person coming into that hospital, they could not chart or enter the IT system, the EHR, for 3 days. Now, in a disaster, you're going to hear me say it over and over again, time is critical. And if somebody is there and willing to work, but their hands are tied for 3 days because they don't have access to the EHR, that is a huge, huge gap. Something to work through, find out if there's a way to expedite access and test it. One of the other anecdotal experiences that I had was when our EHR went down. God forbid that happens to anybody on this call, but it just failed and we had to go back to manual documentation. We never tested all the way through to having to use manual forms. And since the EHR was in place for such a long period of time, the staff turnover and the new employees had no idea what a radiology requisition form even looked like or how to fill it out. So we failed in our preparation on not taking it all the way through to using manual forms and making sure that the new unit secretaries, the new registered nurses, the new pharmacists knew how to use the paper documents, because we are just so reliant on technology. So in summary for technology, basically work closely with your CTO. Make sure that as you're testing your backup and recovery processes that you take it all the way through to manual documentation. Make sure that you've looked at expediting how to get access, how to provide training. Some of the training for the EHRs takes weeks. What is the emergency? How do we get you proficient on the system within a day? Just go through every detail analysis that you possibly can. There is a lot of gaps that you'll be able to identify, and use the PDCA method: plan, do, check, act, or wash, rinse, repeat. Whichever one works for you. If you can understand the technology needs and the technology pitfalls, that will go a long way in expediting your emergency plan. The next component in the before phase has to do with process. And I've got a few of them outlined here, but honestly, there is probably a list 5 times as long that you could add to. I'm trying to hit the high-level processes that really can make a difference in the management of an emergency or disaster. The first thing I have down is census management, and I think that's very well defined in most hospitals, whether it's a natural disaster, whether it's high census brought on by a variety of factors. Obviously, you want to implement your emergency discharge plan, the lower acuity, whoever you can move out, please do that first, and then move down. We always called it the out and down approach. Moving people to rehab centers, long-term acute care centers, get them out into the community, back to their home, and then take your higher acuity patients and move them down so that the critical patients that are coming in will have the beds and the resources to care for them. The other pieces with the plan that we always looked at were where were areas that we could set up discharge lounges. How did we staff them? Where did we find the staff to man those lounges? How did we bring in extra transporters to get patients moved quickly through to the departments or to the discharge area or to their homes? Again, a lot of need for resources. They don't always have to be the highly skilled nursing resources. Sometimes it's just people delivering coffee. Sometimes it's people pushing carts. Whatever it is, you really need a plan to bring in resources, to bring in manpower to help manage whatever situations you are trying to solve for. The other piece with census management that we always looked at is what are the services that can be suspended. Obviously, changing elective surgeries, finding ways to postpone non-critical services in your health center would be a priority. To recap, it's just as I mentioned before, the out and down. How can you get people out to other areas of service delivery so that you can decompress and open up beds in the hospital? License management is the next topic I just want to spend a little bit of time on, because to be honest, it wasn't something that I personally thought of when managing in the hospital. But as we've worked with various clients in different situations, we've seen approaches that are very creative and really would be a good step for you as nurse executive, hospital administrators to think about. What is your state process for license management, license exceptions? What does it take for the governor to create a state of emergency? Some of the situations that we've seen is that in a matter of hours, the nursing board can put in an online application for a temporary license for the state. Texas did that during the hurricanes, and it just created an immense response with many nurses completing that and being able to work in the state of Texas. We are fortunate that the number of compact states has increased over the past couple of years, so that does provide a lot more supply to our emergency situations. However, there is still a very significant number of states that do not belong to the compact, and in the situation with Florida, we saw that the state of Florida, in their response to the disaster situation, they ruled that any nurse with any active unexpired license could work in the state of Florida. And that too actually provided a great response and a strong supply of nurses that were able to go practice in the state of Florida during that time. So my suggestion to you is become familiar with it. If there is a way that you can lobby to get something in place that is flexible, that is easily implemented with the flip of a switch, it is definitely worth the time and effort to do so. The next process area I wanted to talk about has to do with the transportation and the logistics. Now, I'm not saying that this needs to be owned by the nurse executive or by the hospital administrator, but it really does need to be owned by someone that has a very strong understanding of hospital operations as well as the way community resources are structured. And here we come into, there are so many variables, we won't be able to speak to all of them. But you have to be in a situation where you have nurses or healthcare providers that can't get into the hospital or clinical setting, as well as you may have people in the hospital that can't get home, that need to get home, or they need to have some accommodations within the hospital to stay. So overall, you really need to think about transportation. Are there relationships with the school districts so that the bus drivers can be made available to pick up and drop off people? Are there hotels in the area that will clear out their clients so that you can put even patients, but your staff members in case they can't get home, or in case they have to have where they live and their families are, maybe they were destroyed by a tornado and they have no place to live. They're willing to work, but they have no roof over their head. So where can you lodge them, and then how can you transport them back and forth? We've had some very creative, and not to overuse the word, but out-of-the-box solutions that we've worked with clients on and have seen our clients implement. We sometimes refer to it as, the movie title, Planes, Trains, Automobiles. Really have to think creatively of how can you use helicopters, how can you use planes, how can you deploy people quickly? Because if the emergency is in your local area, you may not have local resources for transportation, for lodging, even for staff that can come and solve your crisis with you. You may have to find ways to bring nurses in from all over the country. You may have to find ways of getting family members moved out of their disaster area into a place closer to the hospital so that your nurses and your physicians and your respiratory therapists can continue to work. One nurse executive that I worked with actually had a plan in place to reach out to her board of directors to see what kind of facilities, what kind of transportation solutions they could ask for. And again, not to get too out of the box, but there's been a lot written lately about the use of drones and how can drones be used to establish cell service in areas? How can they be used to deliver supplies to areas where really access is extremely limited? So my message here, my takeaway is really, how can you think outside the box? Again, not to be a broken record, but be bold. Try something that is out of the ordinary, because that may just be the key solution that will solve an almost impossible problem. The other component that we haven't talked about with transportation and logistics, we talked about the out and down method for census management, but if we are transporting patients to different areas of service delivery, what kind of staffing do you need? I would venture to say most of your clinical staff is going to be very busy in the hospital or depending on the nature of the emergency, could be extremely limited, and you're short resources. If you're moving patients to other venues, what kind of staff do you need to accompany them on transport? What kind of staff do you need when they're relocated in a rehab facility or a school? Again, thinking of staffing and how can you get people in quickly and do what you need them to do to maintain the safety of your patients. Moving on, and not to make the situation even more complicated, it is very important in the before stage to identify your business partners and who is it that you are really going to have to rely on to provide services, to provide supplies, to provide staffing in the case of emergencies or disaster situations. This is really, really critical. It's not something that you can put in place quickly, or at least I should say most organizations can't put in quickly. So really identifying who provides the supplies, who provides the food, who provides the various solutions for you just to maintain normal business operations. And again, the nature of this is unknown. You may have shortages in certain supplies. You may have access issues because roads are flooded or trees are down or communities are destroyed. It's just so diverse in what the factors can be. You really have to think both local, but you have to think broader. If the disaster is in my local community, where are the resources that I have to go to? Is it the next state over? Is it a national company? How can I make sure that I have relationships established so I can pull up my contacts in a minute's notice and I can reach out to my partner and say, I need 25 nurses in 48 hours to staff my ICU because 50% of my nurses are now quarantined, or whatever the details of the situation are. Now, in order to do this, this is where the planning comes in. You can't, and let me back up and say, I was never able to get a contract in place very easily on a Saturday afternoon when the disaster happened. It really is important as you're establishing your contacts is to go the full length and complete the contracts. Make sure that the terms and the conditions are identified, that they are resolved, that legal is signed off, and you can truly pick up the phone, call your contact, and deploy whatever actions are needed. I can't tell you the number of calls that I've received over the weekends from clients that have said, I really need your help. And yes, we are more than willing to jump in. I think most good business partners are. But if you don't have that legal document signed, sealed, and delivered, you now have to find legal counsel. You now have to get administrators to sign off on various terms. And to be honest, when you're in the middle of an emergency or an impending emergency, you don't have the time to do that. So definitely being proactive, getting that box checked on your list of things to do will really help tremendously moving along your response. Moving down the list, our communication plan, and we'll go into this a little bit more in the next few slides, but communication is so important. If you think of the nature of the situation, people are anxious. One most important piece to the process is your communication plan. We're going to talk a little bit more about this later in the presentation, but at a minimum, make sure you have a plan for internal and external communication. Again, anxiety, anxiousness running at all high levels during these situations, and people crave information. It's probably best to establish a point of contact that manages all internal messaging as well as external relationships. And honestly, that should not be the nurse executive. It should not be the hospital administrator, but it does need to be someone who is consistent and will provide clear information to the community and the employees. From a disaster recovery standpoint, it sounds bizarre, but you have to consider not having self-service. And I know we are all dependent on it, but we've had clients and hospitals that have used ham radios They've used walkie-talkies. They have actually come up with very, very creative ways to get information out and communication. So might be some dusting off of equipment required, but it's definitely a very, very solid step for backing up your communication. Now continuing in the before segment, looking specifically at people. These really the most important considerations lie in this area. When we talk about people, we can talk about internal, external, a lot of different topics. It's very, very detailed, very complicated. So we're going to start and just do some high-level components of the people concept. The command center is really a very important piece of successful management. We've worked with a client for a number of years that has mastered the operations within the command center. They do a fantastic job making sure that roles and responsibilities are delineated, making sure that schedules are identified. They have solutions for just about everything that has come up, and they are masterful in their communication and in the execution of what has to happen in the command center. They do follow the HICS standards, and this does give them the organization and the responsibilities to make sure that there is no detail that is not considered. Some of the parts of a command center that you have to think about is initially the shifts are long. There's a lot of, even with the best planning, gaps, segments that just haven't been considered. So it is bumpy in the beginning. Probably the first day and a half, you will see the items that hadn't been solved for. But that's okay. That's why you have the experts all together in a room so that the resources and the planning can happen in the moment and success can be achieved. Now, if we move away from the command center discussion and into the internal staff, obviously with the disaster at hand, you're not exactly sure who's going to be available, when they're going to be available. All of that is the unknown. But what can help is if you can create a master schedule. And it doesn't have to be specific to the individual, but specific to the number and type of roles that will be needed. So in your ICU, on 7P, on 7A, how many nurses do you need? In your kitchens, in your respiratory therapy, in your various departments, what is that number that you need? Because you could very well have to expand to a 24/7 support system, which could be different than what you normally run on your weekends, on your holidays, or your off shifts. So considering the ability to build out a master schedule that you can plug in resources as you're in the middle of the emergency planning and staff deployment would definitely get a huge, huge piece of the puzzle solved for. We also have worked with clients that use that master schedule approach. They do it a little bit differently. They use their scheduling software, and they will identify the skill sets that the various employees have, and they can create, if you will, pools of supply members that can be deployed within the hospital to the different units, to the different functions, to the different services. So if you are fortunate enough to have that type of staffing system, you might consider creating a emergency or a disaster deployment plan that pre-populates your staff into these different relief pools with designated roles and responsibilities. External resources, SWAT teams, these are the folks that are in your community or who you have relationships with that can come in a moment's notice that you don't normally think of using, but they do have the knowledge, they do have the ability, they do have the connections to help support what's needed. Some really great resources are if you have a local school of nursing. Not only do you have registered nurses that are instructors, but you have student nurses that can do a phenomenal job of supporting the patients and the needs within the hospital. If there are other local hospitals in the area, they could be a source of support to you. However, they too may be under the same disaster situation. So you might need to look at states or localities that are a little bit further away, and how can you either deploy patients or bring in their staff or use some of their services and delivery systems to augment what is lacking in your system. Additional resources come from those contacts that I talked to you about earlier. Your business partners, if any of them have a rapid response model that they can put in place for you to quickly deliver supplies, to quickly deliver staff. I think when we're looking in a hospital situation, obviously the clinical caregivers are key to not only relieving your own staff, but providing those additional resources that are needed. If you think about, especially in the travel nurse industry with rapid response, these truly are the SWAT team nurses. They come in, they understand they're going to be working long hours, they need to be flexible, they may have to float. Many of them have multiple specialties, and the unique thing too is that they are not emotionally tied as much to the community as your own staff. They are able to focus on the patients there. They are able to focus on the needs of your patients in your community and really help relieve the situations that your teams are going through. And as we talk about bringing in people resources, here is a great opportunity for you to partner with your HR leaders and see what can be done to streamline the hiring process. As a healthcare provider, we know that you are under a tremendous amount of regulations to do things right, to make sure that the screenings are appropriate and that the right individuals are working in your hospitals. However, is there a way to expedite that process? We talked about the access to the IT systems earlier, which is a major hurdle. And you now have that on your checklist to try and eliminate that barrier. But there are other things. What are the processes that HR requires in order to bring in permanent or temporary to augment your staff? Do they have to do an application? If they do, is there a shortened version that can be done? What is your credentialing requirements? Do they have to do a list of background checks that are longer than the Constitution? Can that be shortened? When we were dealing and staffing some of the natural disasters in our country, we worked with clients, and basically it was a rapid drug screen, a national background check, a current TB, a BLS, and any state license. So there are ways that you can build your policies to alter your basic requirements and put in, if you will, an emergency or disaster level requirements. And most states' departments of health have no issue with that whatsoever. Basically, when we're talking about people and planning for an emergency, what we need to do is remember that time is critical. When I used to talk with my CFO, he would say, time is money. When I would talk to a cardiologist in the emergency department, he always would say, time is muscle. When we're talking about emergency planning, we are talking about time is resources, and you need to really evaluate how you can effectively remove the barriers so that you can get the human capital, the human resources on site, boots on the ground within 24 to 48 hours. Determine what those plans are, determine who your partners are, and really put the steps in place so that with a simple phone call, flick of a switch, you can have your resources mobilized to bring the support to your team and community. Now moving into the next phase, the during or activate phase of emergency planning, meaning that we are in the moment. The situation is happening in front of us. The first thing, second thing, third thing is to communicate. I don't know that there's ever a situation when you can over-communicate where the process is at, what the situation is at, or what the plan is. You have to remember that in these situations, people are extremely anxious for their personal safety, for the safety of their family, for the safety of their patients, their friends. It is very, very difficult to live through one of these situations, and people are craving information, and one way to help allay their fears is to give them information. So, as part of the communication plan we talked about earlier, this is really where it goes into play. You have your designated contact, your point of reference that handles the internal and or together the external communication. They are the key collector of details, of information, of facts, and that there is a constant parlayance of the information through social media, if that is available, through internal communication channels. Having that individual with a partnership with local media is just invaluable. So what in your plan is important is to make sure that there are open lines of communication. These people definitely have to be in the command center where decisions are being made. They need to receive what the facts are that have to be relayed to the audience. Then they need to establish what are the check-in points. How are they going to give information to those that need it? But even more importantly, how are they going to get information back? So do they have a forum where they meet with managers regularly and find out what's happening on the units, what's happening in the departments, what is happening with the community, with the staff? What is going on needs to be collected and then analyzed by those in the command center for any gaps, for any single points of failure, for any new information that requires new deployment, new planning. It really, these communication ambassadors, if you want to call them, are really key to give and bring back information so that the command center, the people that are making decisions, are well informed of what's happening. Making sure that the message is scripted. Now, I'm not talking about spending hours on this, but definitely making sure that the message is concise, that it's clear, and that it's factual. There are so many opportunities in situations like this where the message can be expanded when it doesn't need to be. And I don't mean that anybody would purposefully alter the message, but I think it's really important to have scripts that are consistent and informative and factual. And definitely the relationship with the external contacts is critical. I did mention about partners in the media, making sure that there are good relationships and open channels with them. If you think about what happens during a disaster, during an emergency, or even during times of peak census, the people working in the hospital do not know what the situation is with their families, with their friends. The friends and family in the community have no idea what's happening with the nurses, with the therapists, with the clinical and support teams in the hospital. So being able to establish that channel of real time, this is what's going on, this is the situation, again, helps to allay the fears and the anxiety that our teams are feeling. Nimble execution is an interesting concept, and I don't want you to think that I'm contradicting what I said earlier about the importance of planning, putting steps in place, roles and responsibilities, but I bring this point up because even though we've done our planning, even though we've got our steps laid out, it is an emergency, and as we've talked already, it is unpredictable. We don't know what's going to happen. We may be planning for occurrence A, but occurrence W happens, and you have to be nimble. You have to be able to get this information. You have to be able to process it and act on it. One of the most difficult situations is when you have a plan and you can't step outside of the plan to deal with a new set of circumstances. Being able to pivot quickly, analyze in the moment, change direction so that better outcomes are reached is very important. So I do encourage each of you to keep an open mind, find ways to bring new information in, and evaluate the plan and make sure that the plan is addressing the circumstance in the moment. The road back to normal is the topic of our last slide. Even though the disaster is resolving, the emergency situation is coming under control, does not mean that our plan has ended, nor is it complete. This, again, is an important phase for us to think through and be ready to manage. Once the intensity of the situation is resolving, we have to remember the staff and what they've gone through, the patients, what they've gone through, what our community has experienced, and continue to plan and have resources in place at a multitude of levels to help people recover. So if you think about from a staffing standpoint, many of our staff are tired. They've worked long hours, emotional hours. They may need time off because their family is in a bad situation. We had folks in Florida where actually permanent staff had to resign because their homes were destroyed. They had to move in with family in another state. They had no place else to live. So the hospital actually lost a fair number of permanent staff and needed to make sure that they had temporary resources that were able to stay on and manage those vacancies. Additionally, even though the initial cause for a census spike may be resolving, if you had to postpone elective surgeries, if you had to reschedule services, all those cases, all those services need to be rescheduled and re-provided. So even though the causative agent for the census spike may no longer be in play, you will have some very busy departments and some remaining high census as you bring forth those services that were delayed or postponed. So again, important to remember that the replacement staff, the support for your permanent staff needs to continue beyond the actual event itself. The final step in the after scenario is to make sure that you take time and debrief and review those lessons learned. Emergencies are draining on everyone. We need to turn them at least positively to help us plan better in the future. No matter how much time, effort, resources we put into disaster management, there is always something that we learn. There is always something that we can improve. I've been in many debrief conferences, and the smallest suggestion can yield the largest improvements in process. So I strongly encourage you to set debrief sessions quickly after the event, making sure that the right parties are represented and that the information is channeled so that it can help improve going forward. Thank you so much for your time. If you have any questions, please reach out to the number listed below. We are more than happy to try and answer or provide additional information.